Hi, everybody, and welcome to the second webinar in our series presented by Midwifery Access California. My name is Amy Chen, and I'm a senior attorney at the National Health Law Program. Thank you all for being here today. We have a really great panel ahead of us. I want to share first that today's webinar is about Midwives and Medi-Cal, the work of Midwifery Access California, the recent deluge of freestanding birth center closures across the state, and critical actions to stem the tide and preserve maternity care access. You all should see that the Q&A is enabled. Sorry, one second. The Q&A is enabled in the in the webinar. There should be a little box at the bottom. So feel free to put any questions that you have in the box. You won't be able to, let me see, how do I explain it? The attendees won't be able to see all of the questions, but we all, the hosts and the panelists, are able to see them, and we'll be following up with answers to any questions that come up during the course of the webinar via email afterwards. If there's time at the very end of the webinar, we might have a little bit of time to do some live Q&A as well. Next slide, please. So this webinar was created by participants in Midwifery Access California in partnership with a couple of organizations, including my organization, the National Health Law Program. For those who aren't already familiar with NHELP, we're a national nonprofit law firm that works to protect health rights for all and improve health access, equity, and quality, especially for low-income and underserved individuals and families. Here at NHELP, we do our work through litigation, policy, advocacy, and education. We also recently published an update to our Advocates Guide to the Medicaid program, which you can order on our website. Just scan the QR code provided there on the slide. This webinar was also created in partnership with the Western Center on Law and Poverty. The Western Center on Law and Poverty was formed in 1967 by a group of attorneys and legal scholars from USC, UCLA, and Loyola Law Schools. They sought to create a unique organization driven by the belief that low-income Californians deserve the finest possible legal representation before every institution that shapes their lives. For over 55 years now, the Western Center has advocated on behalf of Californians experiencing poverty in every branch of government, from the courts to the legislature. Through the lens of economic and racial justice, the Western Center litigates, educates, and advocates around healthcare, housing, and public benefits policies and administration. To learn more about the Western Center's work, please scan the QR code that you see there on the slide. Funding for this series is provided by the California Nurse-Midwives Foundation. Again, scan that QR code to get to the CNMF's website and also to learn more about their work and funded projects. The California Nurse-Midwives Foundation has funded various initiatives, including direct funding to student midwives. The mission of the California Nurse-Midwives Foundation is to support the development of a diverse midwifery workforce and to increase access to high-quality, culturally congruent midwifery care by centering BIPOC and LGBTQ+ people. The vision of the California Nurse-Midwives Foundation is to eliminate sexual and reproductive health inequities in California by revolutionizing healthcare delivery and ensuring high-quality sexual, reproductive, and birth-related care for every person when and where they need it. So hopefully many of you are already familiar with Midwifery Access California. For those of you who are new to Midwifery Access California or new to this webinar series, Midwifery Access California is a multi-stakeholder coalition started in 2021. As of 2024, the coalition has over 60 partners, including 25 midwifery practices. These midwifery practices comprise certified nurse midwives and licensed midwives and include all kinds of practices, including home birth, freestanding birth centers, and midwives who attend births in the hospital setting. The coalition also includes the LA Department of Public Health, the California Department of Healthcare Services, or DHCS, and various community-based and community-oriented organizations that are listed here. You see some of the logos. That are all working to improve outcomes, increase access to care, and reduce racism-based disparities in maternal health. Midwifery Access California was actually born from the Midwifery Learning Collaborative, which was a 3-year project of the Institute for Medicaid Innovation. The members of this group, the Midwifery Learning Collaborative, envisioned a continued collaboration of diverse healthcare and community-based experts to carry on the work of midwifery integration in California, and thus Midwifery Access California was born. While our coalition does comprise diverse access to midwifery is a crucial strategy for improving reproductive health care access and outcomes in California. Overall, we aim to integrate the midwifery model of care into existing care coalitions, including amplifying and expanding community midwifery. This coalition's initial focus has been on expanding access to midwives for Medi-Cal enrollees. So you all may know that today's webinar was originally intended to educate the public and maternity care stakeholders on the work of Midwifery Access California, and also to engage health plans and other stakeholders who want to expand access to maternity care. Originally, it was intended to have a specific focus on Medi-Cal. However, just a couple weeks ago on August 26th, Cal Matters published a story on the many closures of freestanding birth centers that have taken place across the state, echoing work that Cal Matters has previously done on maternity ward closures across the state. Since the mission of Midwifery Access California is to expand access to midwifery care, we decided to shift the focus of today's webinar to highlight these recently closed birth centers mentioned in the Cal Matters article. We are really grateful to the attendees, to the panelists here today that are going to allow attendees to hear directly from the owners of all of these centers and hear about the strategies necessary to prevent more closures. Just a quick introduction to all of our panelists here today. Our panelists include Dr. Ariana Thompson-Lastad, a midwifery researcher at the UCSF Osher Center for Integrative Health. Also, Bethany Sasaki, certified nurse midwife and owner of Midtown Nurse-Midwives. We also have joining us Caroline Cusenza, licensed midwife and owner of Monterey Birth Wellness Center, as well as Elizabeth Smith, certified nurse midwife and owner of Santa Rosa Midwifery Center, and Karen Roslie, the executive director of Best Start Birth Center, which was the very first licensed and accredited freestanding birth center in California. Pictured here on the slide with midwife Roberta Frank, who started Best Start Birth Center 35 years ago. Now I will pass the mic on to Holly Smith, who is the coordinator for Midwifery Access California.
Hi, everyone. Thank you for being here today. First, I just want to apologize for my video not working. Sometimes things happen on the fly when you're doing a live webinar. So apologies for that, but at least we have audio and you can see our panelists, which is the most important thing. So our objectives today are to review the triple threat in maternity care and reproductive health care and why access to midwives is a key strategy. We're going to learn about the closure of many freestanding birth centers around the state and also why this is happening. And we're going to learn about the work of Midwifery Access California and the tangible strategies advocated by this coalition to stem the tide of closures and improve access to midwifery care, especially in Medi-Cal. So this is a series. I encourage you to go back and see webinar number 1. If for some reason something doesn't make sense or you want to learn more, please go back to that first webinar. But in short, the problems we are experiencing in California are threefold: poorer maternity outcomes than other high-income countries, racism-based disparities are persisting despite efforts to improve outcomes, and lack of access to reproductive health and maternity care. In our last webinar, we discussed how it is the position of our coalition at Midwifery Access California that midwifery care is a strategy that touches on all of these problems. It is just one strategy, though. It's not a silver bullet. It's not the only strategy to curb these trends, but we feel it's a strategy that has not yet been effectively utilized. And throughout the course of my part of the presentation, I'll be adding in some pictures of birth centers and also midwives who are part of Midwifery Access California. This is Midtown Birth Center or Midtown Nurse-Midwives in Sacramento, and Bethany Sasaki is here today as one of our panelists. So for the newbies in the room, the research shows that the midwifery model of care for essentially healthy people results in excellent outcomes for women and birthing people and decreases the outcomes we don't want, like preterm birth, cesarean birth, NICU admissions, neonatal deaths. And also for the newbies, we'll quickly talk about midwives and what that means. We are the primary care birth attendants for essentially healthy people and even moderate risk patients in collaboration with physicians. We are clinical healthcare providers. We do preventative care. We detect abnormal conditions. We refer and consult with physicians when necessary, and we even provide emergency care until the need has resolved or additional assistance can be obtained. Midwives also prescribe and/or administer medications. We can suture lacerations, and we can even manage a number of complications independently within our scope of practice. And nurse midwives in California, because there are two kinds of midwives in California, nurse midwives and licensed midwives. Nurse midwives in California can provide routine gynecologic care, including abortion in the first trimester by both medication and aspiration abortion. And this is Caroline Cusenza, who is here today with a fellow midwife at the Monterey Birth Wellness Center. The great outcomes that result from the midwifery model are really stem from the philosophy and model of care, which is relationship-based and patient-centered. These are just two elements noted here from the International Confederation of Midwives on both the philosophy of care and the model of care. Midwifery care promotes and protects women's human rights. It respects ethnic and cultural diversity. It is based in justice and equity and occurs in partnership with the patient and recognizes the right to self-determination. And in terms of the two elements from the International Confederation of Midwives midwifery model of care, midwives promote and advocate for non-intervention in normal childbirth unless absolutely necessary, and we practice in collaboration and consultation with physicians and other health professionals to meet the needs of the birthing person and the newborn. So keep in mind, these are just two aspects from the philosophy of care and the model of care. You can find more at the International Confederation of Midwives. And I'm not going to go through these here, but we've also placed in these slides some other information. Oh, actually, I'm sorry, let me go back and I was going ahead myself. This is a photo of Kimberly Durden at Kindred Space LA, another participant in Midwifery Access California. Getting ahead of myself. We also are including some slides here about these studies and research in case you want to go back and look through these, especially if you didn't see that first webinar. Of note, midwives in California and the US are very underutilized. And I hate using the term utilized because in fact we should be integrated, not just utilized. But you can see here that the midwifery model of care is the standard in all countries that have better birth outcomes. And you can see that the proportion of midwives to physicians is much higher in those countries that have better birth outcomes. Now, this is not to say that we don't need physicians. Of course, we need our amazing physicians who do specialized care for women with medical needs. But I think it just shows that there's kind of we are underutilized and potentially there's some room for work here. For example, midwives in California make up about a third of the birth providers in the state, and yet we only attend about 11% of the births. So something is askew there, and there is definitely some room for integrating and utilizing midwives in a way that would improve access and outcomes. All right, so let's talk about access. I want to paint the quick picture of what's happening in California for you. But by the way, even though I'm talking about access, it is important to note that these three problems are not mutually exclusive. They are linked, as all complicated problems are. As an example, this research published in JAMA shows the association between loss of obstetric services and increase in preterm birth and unintended out-of-hospital birth. So access, outcomes, and disparities really cannot be separated from each other, but today we're going to look at access. In November of 2023, Kristen Wong and colleagues at Cal Matters published their investigation on the maternity ward closures in California. And they showed that as hospitals close labor wards, large stretches of California are without maternity care. They showed that at least 46 California hospitals have shut down or indefinitely suspended labor and delivery since 2012. And this includes 7 hospitals that closed entirely. And in fact, since the time of this publication, more hospitals have announced maternity wards have announced their closures in just the last few weeks. So it's as if we can't turn around without seeing another report on the loss of services. We truly are falling off the cliff in terms of services and access at this point. In fact, this one just last week about Los Angeles, this one was reported last week, or actually a couple weeks ago now, it looks like, about Los Angeles being the epicenter of urban maternity ward closings. So here, if you want to go to that entire series by CalMatters, you can click that QR code there, and that will bring you to the table of contents. You can see that the first investigation that was done back in November is at the top, and then there at the bottom is the most recent report about the closures of freestanding birth centers. So what this means, as reported by CalMatters, is that California now has 56 rural hospitals, 10 of which are at risk of immediate closure. Only 24 of these 56 rural hospitals have maternity units, and there are approximately 37 critical access hospitals and an official CMS designation for facilities that are pretty far from others and thus are critical access to their communities. There are 37 critical access hospitals in California, and of these, fewer than 10 have a maternity unit. It's hard to conceptualize the closures, unless we have a visual, at least in my opinion. So I hope as this page fills out, you'll kind of see just how dire the situation is in terms of access. Remember, close to 50 maternity wards have closed since 2012, and 29 in the last 3 years, from 2021 to 2024, 29 have closed. So here's what I hope you are getting from this. The take-home point is that we must retain maternity services, and freestanding birth centers have continually stepped in to fill the breach. They did during COVID, and midwives throughout our state's history have stepped up to fill the access gap. And so now it's time to save freestanding birth centers as well. And finally, these last three that are kind of large here, sorry, let's go back. Tapping too fast. Mad River, USC Vertigo Hills, and Hemet Global Medical Center have just announced in the last couple of weeks that they too are closing their maternity units. And being a Northern California person myself, I know just how hard that will be on the community around Mad River Hospital, and I assume the same for Hemet and USC Vertigo Hills. So let's switch gears then and talk about freestanding birth centers and community birth by LMs and CNMs in California. So there are currently around 31 freestanding birth centers in the state, and only 5 are licensed, and I am going to get to that in a moment. And in terms of location, they span most of California. Only 5 are licensed because, as the CalMatters article noted, California has some of the toughest licensing requirements in the country, according to the American Association of Birth Centers. So think of that, 5 birth centers of 31 are licensed. So that's about somewhere in there, 15 to 16%. If licensure is a pathway to reimbursement by health plans, and reimbursement is the pathway to sustainability and keeping the lights on, then the only reason for not achieving licensure is that it must be pretty difficult to do. So 19 freestanding birth centers have closed in the last 4 years. And you can see that here, the red dots. By the way, these dots do not represent the exact location of these birth centers. They are in the correct counties, but they are not in the exact location. So just note that this is kind of referring more to the county that they are in. So you can see these red dots. These closures served clients in San Diego, Imperial, Orange County, Los Angeles, all the way up to Sacramento, Sonoma, Mendocino, Sutter, San Joaquin, San Luis Obispo, Kings County, and more. The list goes on. So here's what it looked like in 2020. Here's what it looks like now in terms of freestanding birth centers across the state. At this rate, and of course this is a projection, this particular screen is a hypothetical, but the fear is, and rightfully so, is that this is potentially what the landscape of freestanding birth centers in California will look like in 2028 if we continue on the course that we are on. So why is this happening? At Midwifery Access California, we have determined that it is due to three main reasons, or rather, the reasons fall into three main buckets, at least here in California. And those buckets are payment, regulations, and workforce. And what we have found is that some aspect of each of these three buckets are to blame when a community midwifery practice fails. It's never just one of these things, although I imagine the panelists in this discussion could probably point to the one thing, the straw that broke the camel's back, so to speak, that was most impactful when they finally made their decision to close. But I also know that they would agree that it's layers and layers of issues over time. So in terms of payment, birth centers have very high fixed costs in terms of equipment, their rent or their mortgage, their staff wages for their front desk staff, billers and coders, nurses, birth assistants, doulas, and more. Luckily, doulas are now able to be reimbursed through Medi-Cal, so that is helpful to some degree. But lots of times folks don't realize that birth centers have a lot of the same built-in needs that hospitals have and that they must pay for. Also, contracting requirements are burdensome and costly, and in some cases impossible to meet those contracting requirements with health plans. On top of this, there's very low reimbursement by Medi-Cal, low reimbursement in general for prenatal care and birth care by commercial payers as well, but certainly it really stands out in Medicaid. Also keep in mind these are low volume practices where there's a significant time requirement for each patient because that is the midwifery model. And so no, the answer is not that midwives in community settings should see more patients and give less time per patient because of course that's the dominant model of care. And that's the model that would not result in the great outcomes that occur when midwifery care is provided. Rather, we should be thinking, how can we pay midwives for the work that they do? Also, there's a great difficulty in getting facility reimbursement unless you are a licensed facility. And as I've said before, there are some issues with licensing that makes it the timing very long and very difficult and very many hoops to jump through, some of which can't be jumped through. And we'll get to that in our panelist discussion as well. Oftentimes, the timing of the payments is mismatched with the costs of delivering care. We've had midwives who have waited a year to be reimbursed since the first time that they sent the bill to the health plan. So that mismatch of services and payments also is not obviously a sustainable way to provide services. In terms of regulatory issues in California, there are significant time delays for licensing of birth centers. There are onerous regulations for birth centers and for midwives alike. So here are a few examples. This is not the entirety of examples, but rather I just pulled out a few to give some idea. So for example, a licensed birth center must be 30 minutes from a hospital that can give emergency obstetrical care. This is not possible for some birth centers, especially now given the current state of hospital closures. So often a birth center's licensure is contingent upon whether that maternity ward will remain open or not. So rather than closing birth centers because a maternity ward has closed and, essentially throwing the baby out with the bathwater, for lack of a better analogy, we should be thinking about whether or not that 30-minute time frame is necessary. Where did it come from? Why did it make it into our statute? These are things that we need to come together and figure out solutions for. Other regulatory issues are that birth centers are held to OSHPD 3 hospital building code standards, even though they are not a hospital. In fact, that is the point of a birth center, is to not be a hospital. We have heard stories from birth centers who take cash pay clients that their renovations cost upwards of $1 million to do what is needed to license their birth centers by California hospital facility code standards. Additionally, the birth center must be a CPSP provider, a provider of comprehensive perinatal services. And up until recently, licensed midwives were not able to attain this. They were not able to become CPSP providers, which automatically meant they could not license their birth centers. So these are just some three biggies that jumped out to us that kind of give some idea of how much the system has layers of issues that have to be worked through on the regulatory side. And finally, the workforce. There is, of course, a maternity workforce shortage in general. So that's one thing that's affecting birth centers. Also, CNMs are paid more in the hospital setting than in the birth center setting. So oftentimes that moves CNMs out of community birth and into hospital birth. Also, some insurers will not reimburse CPMs or licensed midwives in California, and nationally. TRICARE, for example, is one of those payers that will not cover the cost of licensed midwives. What happens then is if you have CNMs who are being paid more in a different setting and licensed midwives that can't get reimbursed from certain payers, then you have a problem, right? Also, I won't get into this very deeply, but the high cost of education leads to midwives working in places and facilities with higher wages rather than high need areas. So what do we do? When a problem is so multi-layered as this, it is easy for stakeholders to not know where they can be helpful in turning around a sinking ship, right? In the Cal Matters article, this was quoted by CDPH, and I know we have folks on the call who are here from the department. This is not to call you out in any way. It's just, I think, a useful example of how sometimes when there are so many things going on, how does one organization or how does one person begin to chip away at the problematic things? In the Cal Matters article, they said we cannot speculate or comment on any reason why providers choose to close these facilities, aren't seeking licensure for new birth centers, or what could be done to improve the process. But we are here to say that at Midwifery Access California, we've done a lot of work to identify the issues that most affect the sustainability of midwifery in general, but also for the sustainability of community midwifery. The work has involved focus groups, interviews, research from research partners, and collaborative brainstorming and strategizing from multiple stakeholders. So we know what needs to happen. The answers are definitely there. So let's start by looking at what we can provide. First, let's talk about payment. All of those things that I just noted under payment: reimbursement, contracting, not getting paid on time, bills being rejected or adjudicated, that kind of thing. Midwifery Access California has created a document called Best Practices in Contracting, Reimbursement, and Advancing Midwifery Care in Medi-Cal. You can go to that QR code there, and it will take you direct to the document. It's a rather long document, so I want to go through a few things today, just a little bit, but I also wanted to let you know that by the end of the week, there will be a video posted that will be a short video that really breaks down each of these things more succinctly in a more digestible way, because, you know, who wants to read a multi-page document, right? But it is there for the taking if you want it. So what we talk about in that document for health plans, there are 5 contracting principles for contracting with midwives that we've determined. First is to contract with midwives as independent providers. So this includes things like not requiring a physician supervisor, not requiring community midwives to have hospital privileges in order to contract with them, not requiring a hospital transfer agreement. There are various things listed there that we go through in detail as to why these things actually suspend the ability of midwives to be able to contract with health plans to deliver services. The second thing, provide health plan enrollees with direct access to midwives. So things like not requiring compulsory affiliation with an IPA, for example, or not requiring a referral or prior authorization for midwifery care. That one tends to be a big one. Number three there, contracting with both licensed midwives and certified nurse midwives. Now, of course, it is California rule that Medi-Cal health plans must have at least one CNM and one LM in their network. Well, this is, of course, insufficient all the way around, but oftentimes, once a health plan has a licensed midwife in their network, they decide not to contract with anymore. Like they've met they've met the threshold, and that's all they need to do. What we are encouraging you to do is to no longer see midwives in California according to a hierarchy. We must be contracting with both licensed midwives and certified nurse midwives so that we can be providing care across the stream in the community, in the home, in birth centers, in the hospital setting. It's important that we consider both of these kinds of midwives in the state. Ensuring access to midwifery services in the home, birth center, clinic, and hospital. So I just talked about that a little bit with number three, and we give some reasons for that and ideas in our contracting principles. And of course, seeing the midwifery model of care as a distinct prenatal, birth, and postpartum model. So that means things like creating standard contracting clauses specific to the midwifery model of care. Things like making it easy for patients to find in-network midwives and provider directories and not just kind of lumping them under obstetric care, for example. Again, if you go to that QR code on the last slide, you can get to that document, and we will have uploaded on our website, Midwifery Access California, or midwiferyaccessca.org by the end of the week, a video that will help you get through that best practices document in more detail. Also in this document, though, is our California midwifery payment model. And it's found on page 26 of the best practices document. And we also have some very, very detailed appendices that include implementation details for this midwifery payment model. I'm very quickly going to give you the Cliff Notes version of the midwifery payment model. There are two big themes that came up for us in designing this model. Number one, we knew we needed to simplify billing and reduce administrative burden and minimize denied claims. And two, ensure that billing and coding reflect the midwifery model of care. So under simplifying billing, we are proposing bundling retrospective payments at points in care that make sense for the midwifery model. This includes combining clinical, non-clinical, and facility payments for the patient and the newborn into one comprehensive bundle at set phases of care. It also means creating an internal billing infrastructure to simplify billing and reimbursement. We understand that, and we know that that can be a barrier for the future for health plans that want to take up a model such as this, but it's not impossible. And creating those code sets that could be used only for bundles within the midwifery model of care. Also creating a predictable revenue flow by creating standards for claims processing to match the timing of payment to the extent that is practicable to the timing of the care provision. So on that second note there, ensuring that billing and coding reflect the midwifery model of care. Number one, we want to ensure that there's reimbursement for dyadic care, meaning both the birthing person and the newborn. We also want to ensure that reimbursement structures do not disincentivize transfer of care to the hospital setting when indicated. A lot of times reimbursement for transfer relies upon a certain time frame that the client remained in the birth center. And you can imagine that that might disincentivize a transfer to the hospital setting if the payment schedule is based on amount of time spent. So setting Medi-Cal fee schedules and health plan reimbursement to reflect actual costs is a really important part of this midwifery payment model, and we kind of beat that drum throughout that document. That we need to consider that midwives also provide intense relational care that involves coordination for social needs, closed loop referrals, enhanced care management, health education, and more, all provided under one roof, and we need to be paying for those things. So the payment model was developed over a year's time with our midwifery focus groups. We did interviews with health plans and midwives and other stakeholders in Midwifery Access California. We utilized the extensive research on midwifery APMs already in use. And should you want to walk through this step by step, you can email us at midwiferyaccessca@gmail.com and we will be in touch with you and set that up. So in short, for health plans on this call, we did the work for you, and there are some extensive resources available. Okay, on to regulations. In terms of regulatory bottlenecks, not being able to be licensed because the birth center has to look and feel like a hospital, or losing your birth center's licensure because the maternity ward near you has shut down, and your licensure is unfortunately contingent on that in California. Or the ability of a midwife to admit their patients to the hospital setting when the patient needs to be transferred. These are all the things that obviously have a regulatory, a CDPH component, a DHCS component, components within the state legislature. So to that end, we have a wonderful resource made by our friends at the Institute for Medicaid Innovation that highlights the need for cross-agency work and community involvement to advance midwifery access. And it goes through each possible stakeholder and what they can do to improve and sustain access. Particularly here, I want to pull this one out. Under the State Health Department strategies, you will see provide educational opportunities to train staff in freestanding birth center licensure practices to provide efficient and effective regulation. So the reason I pulled that out is because this is really key. Our organization has really delineated that a midwifery access and birth center focus group is needed at CDPH. We have an example of this, actually, of a similar work group that Midwifery Access California did alongside the Department of Healthcare Services. And if you go to that QR code there, you will see a document that we called Easy Wins and Other Recommendations for DHCS to Improve Integration of Midwives in Medi-Cal. We haven't always agreed, and we won't always agree on what our wants and their needs and Medi-Cal requirements and federal requirements and so forth. But I think what we do agree on is that access to midwives is important and even a critical for birthing people with Medi-Cal. So with that lens, we have been able to make extensive progress. And we feel like we could do the same with our friends at the Department of Public Health. Maybe it's fits within the work being done at DHCS and the Birthing Care Pathways that's already coordinating interagency work. Maybe it's within the Surgeon General's office and the Strong Start campaign that has recently started to eradicate disparities and maternal death. So I just bring these up as ideas, right? Like there is ample opportunity to create this kind of work group in order to stop what is essentially the disintegration of freestanding birth centers in California. Now on to workforce. I don't want to get too in the weeds about this, particularly because we are low on time and I want to get to our panelist discussion. But workforce is an important part of this complicated problem of birth center closures. In fact, one of the panelists here today can say that the lack of midwives ultimately closed the doors of their birth center. So there is plenty to do. But for today's purposes, I want folks to, I'm just going to go through this kind of quickly. I want folks to take this as the take-home point. The midwifery workforce shortage is also a direct downstream effect of poor payment and reimbursement. If you can't make a living wage, if you have to skip taking a paycheck for yourself as a midwife, a community midwife, if you have to refuse Medi-Cal patients because it will close your doors to other patients, the workforce dwindles. Either people decide that it's not worth it to become a midwife, or they take jobs in higher paying areas and facilities. And people who truly need midwifery care go without. All right, So now we are going to move into our panelist discussion. I'm going to stop my screen share so we can all see each other, minus me because my video is not working. So what is extraordinary, I think, about today's panel is that we don't usually get to hear from folks who close maternity units in hospitals or who have the inside view of why this happens. But today we do get to hear from the real people who have had to close their freestanding birth centers and can tell us about the issues that created an unsustainable environment for freestanding birth centers and potentially what can be done. So I'm going to pass the mic to Liz to begin our discussion.
Hi. Sorry, I was furiously looking at the, the questions that have been coming up in the chat. And I wanted to just briefly say that for the questions that we have answered, you can obviously see those there. And the ones that I haven't answered are the sort of more meaty ones that we hope to be able to get to at some point in time during this webinar. If we're not able to, we will be sending out those responses via email. So I want to start by asking about reimbursement. In the recent article by Cal Matters, one of the interviewees, a midwife, said, if I took Medi-Cal, I would go out of business. In the case of the Medi-Cal midwives here, that has indeed turned out to be the case. Dr. Ariana Thompson-Lastad is an assistant professor of family and community medicine at UCSF and was the primary investigator at the UCSF Osher Center for a study that interviewed over 50 community midwives from 35 counties in order to understand their experience with Medi-Cal and barriers to becoming Medi-Cal providers. Ariana, can you share with us the top line issues that midwives in Medi-Cal face?
Yes, thanks, Liz. Hi, everybody. So, like Liz mentioned, we had the chance to do interviews with close to 60 community midwives in California in all kinds of different parts of the state and working in birth centers as well as home birth and some other settings. And I think the most important thing that we heard was that everyone who we talked to wanted to provide midwifery care to people across the income spectrum, including people who were insured through Medi-Cal. Most people had found it completely prohibitive to become a Medi-Cal provider. And of the people who'd been able to do that, many people weren't able to sustain it, as you'll hear from folks here in a minute. And midwives made really, really clear how the midwifery model of care is a powerful health equity tool because it provides continuity of care and a whole person approach to care in a way that looks really different from hospital-based care. So for example, people are typically providing 5 to 8 visits to a parent and baby in the 6 weeks postpartum. And midwives shared lots of stories with us about how this kind of comprehensive care allowed them to catch complications like postpartum preeclampsia at early stages during scheduled home visits or by being available 24/7 as a known provider on the phone. And I'll just say, reading all the time in the news horrific maternal mortality stories as a researcher, I usually read those stories and think, wow, if that person had had a community midwife providing their care, they would still be alive. Whether or not they also needed to go to the hospital, things might have unfolded in a different way. But community midwives, as Holly's touched on already, had a lot to share about all the barriers and delays that they faced at all stages, particularly with Medi-Cal, from trying to sign up to become a Medi-Cal provider all the way through obtaining reimbursement and sustaining a practice. So I want to share a couple examples of what that looked like, and then people probably will touch on these more from their personal experience in a minute. One example is that midwives, when they apply to be a Medi-Cal provider, have to already have liability insurance secured and paid for, and then can do the Medi-Cal application process. But malpractice insurance, we heard, can cost as much as $80,000 a year for a small birth center, and Medi-Cal can take up to a year to process a midwife's application or a couple of midwives' applications. So people might be paying up to $80,000 a year without having the contract that would actually make it necessary to have that insurance. And then, as is true for other kinds of providers, but has particular consequences for midwifery, Medi-Cal reimbursement is low, unpredictable, and often very, very delayed, which I know has sustainability challenges for, say, a large community health center or a small community hospital, but has very different sustainability challenges for a solo practitioner or a small midwifery run birth center. So one practice, for example, shared with us that they did 15 births for people insured through Medi-Cal, assuming that the reimbursement would eventually come through, and ultimately weren't reimbursed for any of them, which 15 births was a really large number for this kind of small practice. And people typically reported reimbursement through Medi-Cal from $0 for, the global package of perinatal care that they had provided, up through $2,800 per client, despite providing all of the prenatal, postpartum care, and generally births as well. And so midwives said things like, I can't pay someone $25 an hour to fight to get a $25 claim back. That just doesn't compute. And so I can't be a Medi-Cal provider. I'll just say two other things, which one is just that the process of filing claims and then having them rejected is, again, really different for a very small practice than for a larger organization that runs as a Medi-Cal care provider. And in the particular case of birth centers often shared that when they were submitting the claim for the facility fee to Medi-Cal, sometimes would have the facility fee claim rejected, but then all of their claims for that client rejected. And so though the facility fee theoretically was what would make it possible for people to be Medi-Cal providers, it didn't end up coming together. And then people also need to contract with multiple different managed care plans, typically, especially if they're serving clients across multiple counties. And one person shared that their county at that time had 9 managed care plans, and it was understandably not feasible for them as a small group practice to be contracting with 9 different plans. Some of these things aren't unique to Medi-Cal, and I think it's really important to note too that in California, we've heard from billers who bill for midwifery care that private insurance companies in California are often reimbursing much less than in other states. And so there are certainly some issues that need to be resolved across public and private payers. And then there are really some Medi-Cal specific issues around reimbursement and kind of misalignment of what I know many people in the state of California, members of the public and members of state government, really are really committed to birth equity, but the way that Medi-Cal is set up right now does not align well at all with midwifery care. I'll stop there.
Thank you so much for that. It was a very thorough rundown of the many things that midwives in the community setting are dealing with in terms of both Medi-Cal and with commercial insurers as well. Ask a question to Karen. Best Start Birth Center was the first licensed and accredited birth center in the state of California. Best Start operated for 35 years and shut its doors in March of 2024. The midwives at this birth center attended close to 6,000 births and had a significant impact on families in the area, and especially military families in San Diego. Karen is the executive director of Best Start Birth Center. And I know from our discussions that your birth center and the midwives there have contracted with several health plans over the years, and you know firsthand the many ways in which health plans have knowingly or unknowingly confounded, slowed, or prevented contracting with the midwives at the Best Start facility. What comes to mind for you when I say, what are the biggest contracting requirements by health plans, Medi-Cal health plans included, that placed an undue burden on your midwives and the birth center, and in some cases made it impossible to contract with certain plans?
Thank you, Holly. The closure of Best Start Birth Center involved additional variables, but I'm going to speak to for the purpose of this webinar, to those that affect midwives and birth centers across California. I would say first and foremost, some health plans still require a physician supervisor. California law states that CNMs and LMs are independent providers and do not need supervision. This requirement was removed as it was nearly impossible to find a physician willing to supervise another independent provider. For Best Start, contracting was often not an issue with regard to physician supervision. However, being reimbursed after the contract was in place was often nearly impossible. We would get repeated EOB denials stating missing supervising physician, even when the contract clearly stated no physician supervisor required. Another stumbling block that I have heard of from other hospital or other birth centers rather is the need for a formal hospital transfer agreement. It's a roadblock to obtaining contracts, as payers that have this requirement do not allow for any flexibility based on what is available regionally to a birth center and/or community midwife. EMTALA already protects the right of a pregnant person to receive emergency care in the hospital. The intent of a formal hospital transfer agreement is to facilitate a smooth transfer, which is in the best interest of all parties. Best Start is fortunate to have formal transfer hospital agreements with 4 local area hospitals because the hospitals in our area have chose to be good stewards with this regard. However, I've heard of hospitals denying formal transfer agreements. I've heard it is due to a competitive healthcare landscape, whereas hospitals have no incentive to work with a community midwife or birth center, and also that birth centers are considered competitors of the hospital. Additionally, quality of care will never be at the forefront as long as competition for reimbursement is based on billable codes. If this is a defining force, birth centers can never compete because we have very few codes we can even bill. The payer model needs to reward the value of midwifery and birth center care because of the excellent outcomes for low-risk pregnancies. Birth centers and midwives need to be fully accepted into the medical community, and ideally, every hospital would have a direct linkage to at least one freestanding birth center with a formal transfer agreement in place. In closing, there are some payers who are better than others with providing fair reimbursement. For example, there is a local San Diego Medi-Cal managed care plan who has made contracting and reimbursement easy compared to other MCO plans as well as commercial plans. They did their own research and seemingly understood that the midwifery model would be cost-saving overall while providing excellent outcomes. The point is that if health plans want to work effectively with midwives and freestanding birth centers, they can. I hope the health plans consider the best practices put forward by this group. Thank you.
Thanks so much for that, Karen.
Thank
so
you.
I just wanted, oh, go ahead.
Sorry, go ahead. No, go ahead. No, go ahead.
I was just going to say that, the concept of a transfer agreement, sometimes, the details get lost for folks who aren't familiar with how community birth works. Transfer agreements aren't necessary. What we want to see are transfer relationships between midwives and the hospitals that they are transferring to. And in fact, California is working on this right now. CMQCC has a community birth partnership initiative, which is intending to help build those relationships between community midwives and hospitals so that transfers go smoothly and so that the patient's wishes are cared for and that their values are adhered to and that kind of thing. But transfer agreements really essentially make it so that birth centers only survive if they get permission from hospitals to do so. And obviously that creates lots of questions around competition and just the fact that people should have access to freestanding birth centers regardless of what certain people and certain levels of hospital status feel about that. All right, Liz, did you have something you want to add to that? Sorry, I cut you off.
No, I was just gonna jump into our next question.
Okay, sounds good. Go ahead.
Okay.
Or if there is anything else from other panelists who want to. All right, go ahead, Liz. Sorry.
Yeah, thank you, Karen, and thank you to both you and Roberta for all of the years of service to your community and to not just to the community, but also to the advocacy work that you've done in helping to try to promote an access to this high quality care for folks. I do want to go back to another question about reimbursement. I'm reminded, Karen, of something that you would often say in our Midwifery Access California meetings, that the comprehensive perinatal services, the CPSP reimbursements, were one of the few things that were helping make ends meet at your birth center, meaning the fact that your birth center could bill through the CPSP program for the enhanced care management that you naturally provide under the midwifery model of care, and that reimbursement pathway was a lifesaver. Now that CPSP no longer exists in the way it previously did and has never historically been available to licensed midwives, it is now under health plans under CalAIM will independently determine how these enhanced services are reimbursed. We're hearing from midwives saying that it is really hard to help health plans understand how the midwifery model inherently incorporates extensive enhanced care management because the connections to social services, referrals, comprehensive prenatal and postpartum education, lactation support, and more are built into the model of care. Caroline, you are the owner and practicing midwife at the Monterey Birth Center. This is the first and only freestanding birth center on the Monterey Peninsula that unfortunately closed its doors this month due to inability to financially support the cost of care. Can you paint a picture of what a typical patient gets in your practice so that folks can understand what's different in the midwifery model of care?
Yes, you can. Can you hear me, Liz?
Yeah, totally.
Absolutely. Thank you so much. Yeah, and I think that I'll outline kind of some of the larger things, the bigger differences that I think people need to know, starting with longer visits. Typical community midwives will typically spend anywhere from 30 to 60 minutes with each client/patient at each visit. And what this allows us to do is it allows us to have time to educate and counsel them, as well as it just increases overall communication in both directions. It gives us time to really review common complaints of pregnancy and helping to address things that go beyond the physical assessment of what I think the typical medical model is. So I think that's probably one of the larger biggest differences. Another area, which of course fits right into what the CPSP program does, which is nutrition and lifestyle things such as fitness. We're going to focus on keeping our birthing person healthy and low risk. We counsel on things like supplements, over-the-counter remedies, herbal remedies, as well as how to avoid and identify toxic substances. Lifestyle changes and coaching for those changes. Examples of that might be better sleep hygiene and how to address stress, how to do effective stress reduction. Other things that we also will talk about, we'll spend special time. There may be some specialized counseling for people and monitoring for folks that are at risk for gestational diabetes or pregnancy-induced hypertension. That's another common thing that we are pretty good. I feel like midwives are great at preventing. Some of the other areas that we address are social and issues, as well as mental health. We provide regular screenings and risk assessments, both in the prenatal and the postpartum period. Support, we give support directly, but we also give referrals for those that need it. Many times what the social issues that we're addressing is really just simply about helping families transition to adding that extra person into their family. So navigating the changes that we all have when we're pregnant, we're giving birth, and in the postpartum. And it's just connecting families with resources. That's a big part of what we do to make sure that they're aware of what's out there for them and making sure that they're getting their needs met. There's a lot of management, I would say, during that period. But the thing that I want to highlight the most is probably maybe one of the biggest differences that we also have is the care that is received in the postpartum period. This is where the midwifery model of care shines the brightest, in my opinion. Typically, midwives, as Ariana mentioned earlier, are seeing their clients 4 to 8 times in the postpartum period during that 6-week period. And these visits are typically lasting an hour or more. Those visits are also the frequency and the timing is also tailored specifically to that birthing person's needs. Are they struggling with depression and anxiety? Are they having issues with lactation? Sometimes when we have folks that are having these issues, they're coming in weekly during that 6-week period. That's not unusual. We feel that these regular visits are going to increase safety during that period of time. And of course, the postpartum, many of you know this, and maybe some of you don't, but the postpartum period is the period where we'll see the most maternal mortality. So this increased visit increases safety. We have more eyes on our people. It gives us more opportunities to screen for preeclampsia and PMAD, perinatal mood and anxiety disorders. And then circling back to the first point that I made about increased communication with those longer visits, we also feel like our clients or patients are more likely to communicate their symptoms and ask questions about their symptoms because of the relationship that we were able to forge during those longer visits. Postpartum visits in the midwifery model also include, not only include the birthing person, but they also include the infant. So that's more opportunities to examine the infant and monitor the infant's weight gain, addressing lactation issues as they come up before they become acute or become real major problems, or the birthing person decides not to continue with breastfeeding or chest feeding. And then more opportunities to observe family bonding, which is also a big part of the social aspect. We're able to kind of assess that things are going well, that the family and the baby are bonding well. These are the differences that are going to lead to improved outcomes. The more time that we spend with them, the more support that we're able to give.
Thank you, Caroline. For those of you that want kind of a written version of this, what Caroline just went through, you can see it on our website under midwife-led care. There's a why midwife-led care that goes through some of the data that Holly had been talking about, but there's also the midwifery model of care, and it provides some of the information that Caroline just went through about the enhanced care that people receive, especially with community-based midwifery, not midwives that are integrated into the routine model of care.
Yeah, thank you so much for that, Caroline. I just want to really amplify what you said about that enhanced care management is key. It takes time. It builds a relationship with the patient, and that relationship and that time, I think, is really directly results in the improved outcomes that midwives get when they can actually apply the midwifery model. So it's good for patients, but it's also good for health plans in the sense that they are meeting their value goals, as well as, we brought up before that birth centers have certain fixed costs, just like hospitals do. But what one gets from a client who is in the care of a midwife at a birth center, the value of that and the cost of that is still so much cheaper than what a health plan would pay for a client being seen in the hospital setting. And the outcome and the prevention and everything that they get from it is so much more. And I also just wanted to, I was hoping folks really heard that sometimes patients are being seen weekly in the postpartum period, in those first 6 weeks postpartum. And we know that the postpartum period is that time where the majority of maternal mortality takes place. So again, just something conceptually that the midwifery model gives that improves quality and safety and outcomes. All right, let me find, I think I am up for the next question. All right, Elizabeth, you are the owner of Santa Rosa Birth Center, the second oldest birth center in California. The state licensed and nationally accredited birth center closed its doors to birthing patients last year. However, you still have an outpatient practice and you care for patients across the lifespan, including prenatal care, birth care in the hospital setting, menopause care, abortion care, GYN care, and more. Notably, your birth center and current practice cares for primarily Medi-Cal recipients, as well as many commercial insurance contracts. You have a deep understanding of what it takes to sustain the midwifery model that Caroline just described. And you have also been an outspoken advocate for enhanced reimbursement of birth centers and midwifery care. In addition, you have advocated for other ways that the state can stabilize and sustain birth centers. Can you talk about that a bit?
Thank you. Yes. So we've just spent almost an hour talking about the barriers to birth centers and the benefits of birth center care and midwifery care in the community. And there's not really anything that I can add to that because all of it is true and all of it is my lived experience at the Santa Rosa Birth Center. But what I can say is that even when everything is right, like at my birth center, we were licensed, we were accredited, we were Medi-Cal enrolled, we had managed care contracts, we had private commercial insurance contracts. We got paid on a regular basis from Medi-Cal their maximum fee schedule. Even then, the birth center model was unsustainable. And that is the saddest part about all of this. It just doesn't work. The birth center model is unsustainable. And I have sung the same song. I giggle when you say I'm a tireless advocate, because I'm an advocate for increased reimbursement. At the end of the day, all of the barriers that we've identified here, the licensing issues, the contracting issues, the issues that I think Bethany's going to talk about next, all lead to a birth center's ability to be paid. And that's what we need to keep the lights on, to keep good people employed, to recruit good providers, and to provide the awesome care that Caroline just described. And the money just isn't there, and it's just not enough. Reimbursement rates are profoundly low, and they don't change and haven't changed in response to economic times. And I have two fantastic examples from my own birth center that really highlight this. Just for a little bit of background, Medi-Cal reimbursement for comprehensive birth center care, and that includes prenatal care, birth care, postpartum care, everything that Caroline described, is right around $4,000. $4,000. And that's if the birth occurs in the birth center. If that birthing family doesn't birth in the birth center, or has to, or chooses not to birth in the birth center, that reimbursement goes down immediately by almost half, and would be even less than that, depending on how much care that midwife provided. Most births that transfer out of the birth center continue with their midwives in the postpartum period, and yet that's not reflected in enhanced reimbursement. Add to that the fact that Medi-Cal reimbursement has not changed in my tenure owning a birth center, which is over 10 years. They just approved and passed a targeted rate increase last year that was supposed to start on January 1st of this year. To date, September 10th of 2024, and I think most people have not seen a dime of that targeted rate increase. That delay in payment is profound for practices the size of mine and the size of most birth centers. I think it's profound for most businesses if their reimbursement or their income was shackled by that much. A second example are our insurance contracts. I have insurance contracts with the two largest payers in Sonoma County, where I practice, outside of Kaiser. I don't have Kaiser contract. I've had those contracts since 2014 and 2017, respectively. Those contracts pay, according to contracted rates, the same now as they did at their inception, which means that my reimbursement from the two largest payers in Sonoma County have not changed in 10 years. I cannot pay 2024 costs with 2014 dollars. It just doesn't work. And this payment model is unlike any other economic force in the country. Healthcare financing, the healthcare economists can probably speak to this a little bit better than I can, but we must increase reimbursement. And in my opinion, and I'm going to take this to a little solutions section for quickly, I mean, I think the quickest and the simplest, the easiest way to stop the hemorrhaging of birth centers is just to increase the amount of money paid within the existing payment structure. It's a Band-Aid. We need to overhaul the payment structure. We need a new paradigm, and we're working on that. But right now, we can stop the hemorrhaging by simply increasing the money. We can overall increase reimbursement of specific maternity codes, and we can pay the global OB in full to birth centers and community midwives, regardless of the location of birth. That doesn't require any systems changes other than amounts of money. I think that this is quick. I think this can be spearheaded by Medi-Cal and Medi-Cal managed cares, and it would target existing birth centers who are already providing an established care in their communities. We have relationships with hospitals, we have relationships with clients, and this would stop closures that are existing. Of course, it's Band-Aid. We need bigger payment. We need overall, we need to look at licensure so that more people can be paid, more people can contract and take advantage of things. And we need the enhanced payment model. Holly presented the California model. There are lots of other models we can look at. That's probably a topic for another webinar, but that's what can happen right now, right away, and would, I think, stop that projected loss that Holly presented on that topic. And finally, I really want to say, I've been told so many times by business folks, by MBAs, by healthcare economists, that the birth center model just doesn't work. It's just not a good business model. Our income doesn't cover our expenses. And that's the bottom line of what a birth center or what a business is, right? And in many ways, they're right. But what we're doing right now isn't working either. Hospitals are closing. There are huge parts of California that don't have OB providers. And most importantly, outcomes are terrible, especially among certain communities. So what we've got isn't working, and birth centers and midwifery care are established solutions to some of these problems. I think it behooves us all to figure out how we can make a payment model work so that we're successful not only in outcomes, but in finances as well.
Thank you, Elizabeth, for those
Sorry,
very
took a little soapbox moment, but
yeah.
No, I think
those are
fair.
really great. Oh, go ahead, Holly.
I say I think it's really fair, and I'm really happy that you gave some, right now ideas that I think you're right. Also, state intervention in this moment, it is not going to solve the problem that we're talking about in terms of future sustainability of birth centers according to the current way folks are reimbursed. But nonetheless, the state has intervened for hospitals, for example, through directed funding last year for the distressed hospital funding. I would hope that in the future, if we do that for maternity units in California, that we also consider helping freestanding birth centers in the same way for equity reasons. All right, I think we're going to move on to our next question for Bethany.
Yeah, and before we fully move on, I just want to say, because I think we've been talking a lot about the inadequate reimbursement for midwives and the significant time and quality investment that you receive from midwifery care. And I just want to point out that I still think the overall cost to the system, if you reimburse midwives at a sustainable rate, is going to be incredibly cost savings. And I think that that's a really important thing for us to note. The fixed costs at a hospital are far, far, far higher than the fixed cost at a birth center. And the outcomes that people are going to get in that birth center improved as compared to the outcomes in the hospital when we're looking globally and generally. And that's not to say that we absolutely need hospital care. There is emergencies that require hospital care. There are people who require hospital-based services that we can't provide in the community setting. But it's really important when we're talking about all of the increased reimbursement that midwives need, that we think about the fact that overall that is going to be incredibly cost savings to the larger system. But I do want to touch on the regulations that are impeding birth center licensure. So I'm going to turn to you, Bethany. So again, licensure is a pathway to reimbursement. So anything that impedes licensure is going to impact sustainability. And Bethany, you're the owner and practicing midwife at Midtown Nurse-Midwives, a birth center in Midtown, Sacramento. Midtown is an accredited birth center by the Council for Accreditation of Birth Centers, and you are the president of the California affiliate of the American Association of Birth Centers. You have attempted to attain site licensure for your birth center for many years. In California, freestanding birth centers, which are intended to be home-like environments, are unnecessarily held to the same building standards and facility codes requirements as hospitals. In your case, your birth center did not meet the HVAC requirements for hospitals. Can you tell us a little bit more about what happened at your facility and what you see as possible solutions?
I would love to. When we were opening our birth center, we did our due diligence. We built our birth rooms out to the requirements from the state, and we applied for licensure. After months of back and forth, our application was ultimately denied for one detail in the HVAC code. They gave me the option of upgrading the building to bring the ductwork up to OSHPD 3 code. OSHPD 3 is the code used for hospitals, which would have cost over $50,000 and would have destroyed the historic nature of our building. So we just couldn't do it while trying to open an entire birth center. We opened anyway without the license. We did get nationally accredited, and the accreditation standards does have facility building codes in it, which we fully met. We secured enough contracts without the license to survive. We would have secured a lot more contracts with a license, but we got some good ones, specifically TRICARE. We were right between two Air Force bases up here in Sacramento. And for those who don't know, TRICARE is the federal healthcare plan for military families, and we're honored to take care of those military families. Out of the blue this winter, TRICARE canceled all the contracts with all the birth centers across the country who didn't have a state-issued license. They reported that those contracts were approved in error. I knew right when that happened that this was certain death for our birth center. So I petitioned the Department of Public Health for an emergency waiver of the one element of the HVAC code. I petitioned in writing. I never received a response from the Department of Public Health. And now our birth center is closing. The answer to this issue is so simple. I strongly suggest that the Department of Public Health adopt a pathway to licensure, which allows a national accreditation, the CABC accreditation, to be a pathway to licensure. I then suggest that the DPH convene a group of birth center experts to advise them on appropriate standards, to simplify the regulations to be in line with the rest of the country. I'd also like to point out that the regulations were different prior to 2018. When Elizabeth and Karen's birth centers were licensed, the licensure was a completely different system. Only one birth center has been licensed since the system changed.
Thank you for that, Bethany. Our proposal, and something that we have talked about at Midwifery Access California, is given what we saw on those slides of the rapid closures of birth centers, and that there are so few being licensed, that every freestanding birth center that would otherwise be licensed, if not for some kind of simple OSHPD 3 building code issue, should be issued a waiver for licensure. It's critical at this moment, and I am, I'm feeling what you're saying here. I'm upset that you never got a response from the department. I feel it, that it feels like sometimes we're screaming into a tunnel, right? So I hope folks are hearing what we're saying, that there are strategies in the moment, in the now, that Bethany just gave, that Elizabeth just gave, that will sustain the birth centers that are currently open, and hopefully in the future can get us to a point where we are also considering how to not just sustain them, but help freestanding birth centers to thrive in the maternity access space. I want to thank everybody for being here. We are 3 minutes over. I want to thank all of our panelists, as well as the National Health Law Program and Western Center for Law and Poverty, and the California Nurse-Midwives Foundation for partnering with us to make this webinar possible. And you can go to our website to see our future webinars coming up. And Liz and I look forward to hearing from the many people on this call today, so we can work together around these strategies. All right, take care, everybody. Thank you. Bye.